Thank you, and good afternoon, everyone. Thanks for staying, and I would like once again to thank the organization, especially Ingrid, for inviting me to come to beautiful London again. Yeah, as Ingrid was saying, so the goal for this lecture is actually not to do an exhaustive review about FCD, because we don't have time for that, but to provide you with some evidence from the literature to kind of trying to settle this debate on whether FCD is an independent condition and a settled disorder that we know all about it, or is it a concept still in development. So this is what we will be discussing. And nothing better, I think, than starting with a clinical vignette. This is a real case. So I received this referral while I was working in Edinburgh from a GP. And the GP said, so dear doctor, I'll be grateful if you could assess this 48-year-old woman. She has noticed considerable worsening with her short-term memory for the past year. She describes word-finding difficulties, even with very simple words. She's unable to multitask, extremely anxious about dementia. Because her father had dementia, and she cared for him until the end. I performed the cognitive screening test, and she scored 30 out of 30 at first attempt. As our memory complaints have been a source of concern, I'll be grateful if you could see her. And I'm sure for those of you in the room that do memory clinics, you will be familiar with this sort of referrals. And this is where the clinical gap lies, because we repeatedly see these patients with some sort of inconsistency, so very distressing memory complaints, but then they kind of have a normal examination, normal MRI, and what do you do with them? And patients with functional cognitive disorders, until very recently, they didn't fit the traditional boxes that we tend to think about. So about this patient, does this patient have Alzheimer's? Is she on a path, on a route to develop dementia? Is this depression? Could this be malingering? Something else? And then we see the patient, and she provides several examples. She forgets conversations minutes later, can't find the names of people she knows well, but then remembers afterwards, enters rooms and forgets why, goes blank at points. This is all that she said during the appointment. Long-term memory, driving and navigation, completely unremarkable. Everything feels hard work, though, and she has to rely on calendars and lists for everything. No sense of progression, rates her memories 2 out of 10, despite remaining completely independent, managing finances, continuing to work, and she scored 97 out of 100 in the Addenbrooke's, and the MRI was unremarkable, as I said. So this patient has a functional cognitive disorder based on the presence of internal inconsistency, and we are going to speak to you about why we make this diagnosis. So as I was saying, this is a common referral, and this is a common cause for people to present to memory clinics, represents around a quarter of patients we see. And if left untreated, this is a chronic and stable condition, okay? So symptoms won't go away unless we do something about it. Despite that, over the years, this was often framed with very heterogeneous labels, like in different ways. Often patients receive quite misleading labels, such as stress-related memory disorder, depressive pseudo-dementia. These tend to attain a cause for the symptoms that is not often the case, so patients might not be depressed or stressed. And also other kind of dismissive labels, such as worried well, when we know that these patients aren't well, otherwise they wouldn't be presenting. So we set up a group of people back in 2022 that basically we recruited people that were cognitive experts worldwide, and we tried to gather their opinions about FCD and their perspectives on how to diagnose and manage this condition. And what we asked them was to appraise very simple, straightforward clinical scenarios of people with Alzheimer's disease, primary progressive aphasia, for example, and also FCD. And we found some interesting things. For example, just based on the clinical history and the bedside examination, they were completely able to discriminate between what was FCD and what was Alzheimer's disease or primary progressive aphasia. Although the way they framed and then conceptualized this condition, FCD, was very heterogeneous, and this is among experts, so imagine among other clinicians, for example, in primary care. So what we saw was that the diagnosis and then obviously follow-up and treatment still depends heavily on clinical judgment. So we need to find a way to standardize this. So the diagnosis is slowly shifting from being a diagnosis of exclusion, so ruling out all of the causes for memory complaint, mainly Alzheimer's disease, to establishing a positive diagnosis, so identifying the specific features that make us diagnose this condition. You'll be familiar that this is similar to what happened with other functional neurological disorders. So nowadays we make a rule-in diagnosis, and we can consider functional cognitive disorder to be the cognitive subtype of FND. So the current diagnostic criteria that were proposed back in 2020 rely on this concept of internal inconsistency. What is this? This is people that present with persistent cognitive difficulties, mainly in attention, concentration, and memory, although there's a mismatch between these complaints and then preserved abilities in conversation and everyday function, preserved or inconsistent objective cognitive performance, and there's this phenomenon of symptoms worsening when they are the focus of attention. We know that psychological factors may be important for the pathophysiology, but they can be absent, and if they are absent, we can still make this diagnosis, and then, as you know, this is not better explained by another disorder and causes significant distress. I won't speak a lot about mechanisms because my colleagues will touch on this, but there have been a lot of mechanisms advanced and hypothesized over the years for these symptoms. It's important to say that we still lack a clear mechanistic model for this condition, so probably what we see is a combination of different mechanisms in different patient phenotypes. The model we use in Edinburgh basically emphasizes the self-monitoring and attention. So we know that patients can experience memory lapses and concentration problems for different reasons. But what distinguishes FCD is not the symptoms per se, but the interpretation that the patients have of the symptoms. So if they have, for example, memory perfectionism, they have high expectations for their memory, they will start self-monitoring their symptoms, noticing them more frequently, and then they might develop performance anxiety, anticipation of failure. This will drive negative emotions over time, and then they will develop very often catastrophizing thoughts, so unhelpful thoughts. They might think, well, I'll never get better, surely I have dementia, and also defensive actions, for example, relying on calendars and lists for everything and avoiding cognitive tasks. And over time, this perpetuates the symptoms and they become chronic. And this is important to establish these models because these become our targets for treatment. We also observed that around 50% of patients have an acute onset of symptoms. So patients that are more predisposed, for example, with other medical comorbidities or functional disorders, if then they experience a precipitating event, such as a mild traumatic brain injury, migraine, dissociative events, syncope, medication changes, they experience memory symptoms at first. And this is a physiogenic process. But what happens is that over time, if there is an interplay between physiogenic and psychogenic processes, then the symptoms may become chronic, and we hypothesize that then they fail to habituate to the symptoms and develop a functional cognitive disorder. And this is more common if they have other perpetuating factors, including not receiving a diagnosis, so diagnostic uncertainty, lack of treatment, being prescribed sedatives and opioids, obsessional thought structures, and so on. So for this first part, we know that the syndrome clearly exists. It is seen and recognized across memory clinics internationally, but we need to identify a clinical profile that can be standardized. So at first, we were inquiring the literature to see what the literature had to tell us about clinical features that discriminate between FCD and dementia. And we saw, for example, that patients with FCD are younger, more educated, they speak for a longer time, they have more cognitive complaints, they can bring a written list of symptoms. Symptoms tend to fluctuate over time. They also had more comorbidities, including physical comorbidities, sleep disturbances, and so on. We also, if we look at the neuropsychological performance, more than just standalone cognitive tests and quantitative scores, it is more important to look at the qualitative aspects of the neuropsychological evaluation. And namely, these patients tend to give the approximate answers, they tend to say a lot of self-critical comments during the test, giving up quickly, I can't, I won't be able to do this. They struggle more with simple tasks rather than complex ones. We can see that the symptoms attenuate during casual conversation when the attention is diverted away from the symptoms. And we can also observe the patients and see that they have autonomic signs during the test, sweating, hyperventilating, and sensory overload. We have had several patients come into the clinic with our classes. So we try to integrate and incorporate all these findings into a diagnostic checklist. And again, with the same group of people we had gathered before. And we developed a diagnostic checklist that tries to discriminate between FCD and other neurocognitive disorders. And this also integrates, of course, clinical expertise, which is very important. So the checklist is here. I won't go through it in detail. You can check later, but it was retrospectively validated in 239 patients across 8 centers here in the UK. And if patients had 6 or more points, then we could be reasonably confident that they had functional cognitive disorder with a specificity of 97%. And I think more than that, it's important that checklists like this and knowledge of these positive features gets across, because this can also serve an educational point for people to recognize this in clinic. But we need better biomarkers, and we know that, and other groups have been looking recently at structural brain alterations. And for example, this group found that people that had higher severity of symptoms, so more symptoms, also had larger right amygdala volumes. So the amygdala might play a role here. And they also found, interestingly, that the amygdala volume and the frontal gyrus volume also then impacted on treatment response to CBT, for example. And this is just preliminary data, okay? Bear in mind that we are still conducting this study, but we are now doing a task fMRI study with UK Biobank dataset with a proxy of FCD people, and we were able to identify 3 different functional cognitive disorder subtypes based on patterns of whole brain activation, also amygdala activation, behavioral measures, and cognitive data. And we found essentially 3 different subtypes. So there's the green one you see here with highest brain activation, faster cognitive responses. This is probably the people we see with higher cognitive reserve, more obsessional thoughts, more perfectionist. Then we have like a cluster that you see here in blue with lower symptom rate, average cognition, and also low neural activation. And then another subtype, which is the one with psychiatric distress, so higher anxiety, depression, neuroticism, which interestingly is, as we heard in this morning, is linked to poorer general health, so more comorbidities in general, frailty, slower reaction times. And this obviously needs to be validated and better studied, but it's interesting because it mimics what we see in clinical practice as well. Also, Alan and I thought it would be interesting to train machine learning models with UK Biobank datasets, and we were basically introducing a whole lot of variables from the UK Biobank dataset, including imaging, cognitive, genetics, and so on. And this is completely blind, so we just introduce all these variables into the model, and we see what comes out of it. And the models found that the variables that are most discriminatory between functional cognitive disorder and dementia are actually age, which is not surprising, but also traumatic adverse life events, and then in third, polygenic risk score. So probably these 2 groups have different genetic backgrounds. I said in the beginning that most of these people, their symptoms are stable and remain chronic over time if left untreated. It's potentially useful and important to keep in mind that some of these patients might actually develop Alzheimer's disease in the future, as we see, for example, with functional movement disorders and Parkinson's disease. And we studied in a group of people that we call the progressors, we studied potential red flags that could identify this particular subtype. And having language or praxis disturbances, the relatives being concerned about the patient's symptoms, major sleep difficulties, and lower cognitive scores at presentation were the things that came across as potential red flags to identify this group. These are the patients you want to follow up over time. Interestingly, things that did not discriminate between progressors and non-progressors were stressful events at onset, you might be surprised with this, depression, anxiety, and also family history of dementia. Okay, so on a good note, we know that if we do something, patients with functional cognitive disorder can improve. This is a patient of ours that participated in our trial in Edinburgh, and Suzanne gave an interview to the iPaper that I thought would be interesting just to bring here, because a GP suggested that she might have a brain damage caused by a recent COVID infection. But then she participated in our trial and she did the treatment. And then after that, she was able to say, well, I still recognize I experienced some memory lapses from my fatigue, but the FCD element has gone away. So like the concern and the preoccupation, the monitoring of the symptoms had gone away. So about treatment, my colleagues will speak a lot about that. Just to give you a brief note that there have been a few treatments developed over the last few years. So this is one, we developed a workbook that is an adaptation of the functional seizures workbook developed by Kurt LaFrance. This is being tested at the moment in US, and Norman Poole and Sarah Cope here in the panel as well. They developed very interesting online group therapy based on acceptance and commitment therapy for FCD. Also, a group in Canada tested, in this small pilot feasibility trial, they tested CBT against cognitive rehabilitation, and both groups seem to improve in a similar fashion. And we developed a self-help digital intervention, which is just a brief program that is done on a mobile app, and it's freely available. And we run a feasibility trial, and also patients seem to improve even after a short treatment in terms of quality of life and depressive symptoms. So just on a final note, there's a lot of hype about biomarkers. I'm sure Jeremy would be keen to speak about this as well. But patients with functional cognitive disorders, they can test positively for biomarkers, okay? They can have this sign of potentially Alzheimer's disease. However, this can be an incidental finding, especially with aging. And also, even if they are positive, we don't know whether and if they will develop Alzheimer's disease. So what we know is that this can cause, because of a combination of worry and memory introspection, this can cause FCD de novo. So we decided to write a commentary for the Neurology Journal, and that you see here, and Jeremy and I were kind of alerting for this, for the risks of adopting these purely biological and reductionist positions, and talking about biomarkers as the new standard of care for all neurocognitive disorders. And we're kind of defending that we still need to rely on the biopsychosocial formulation. So to finish, so where does FCD sit at the moment? We know that it's both a clinical recognizable syndrome, but it's not a finished diagnosis. And I think about it now as a transdiagnostic concept, okay? So a lot of people can potentially benefit from this sort of approach and treatment, but this is still a developing framework that can be useful for a previously neglected group of people that were not included in clinical trials, for example. And we know, like I presented, that this is conceptually related to other functional neurological disorders. Issues with functional cognitive disorder, the big one is risks of being used as a wastebasket diagnosis. So anyone that does not have Alzheimer's disease then has functional cognitive disorder. We also want to argue against that, because there are other things that are more common than FCD, and they, if we call them FCD, then there's a risk they might be missed. And these are treatable conditions. So for example, migraine, sleep apnea, medication side effects. These are, yeah, no final slide? No? Final slide. So these are potentially, like I was saying, these are commoner conditions and potentially missed and treatable, so we need to look for them. So final slide, like I was saying. So where are we at the moment? What remains in development? We need better boundaries and you know, tighter boundaries in terms of where does FCD sit in relation to health anxiety, depression, cognitive consequences of insomnia, pain, and fatigue. We need to better understand the relationship between FCD and neurodegeneration. We need better biomarkers, and here I would highlight as well the integration of patient-reported experiences, and I know Norman is also doing some work on that. We need to understand more about mechanisms, and there's probably a combination of different ones for different patients, and about the multidisciplinary treatment pathways you'll hear in a second. So that's why we put together a panel of neurologists, psychiatrists, and psychologists, because you probably need to have a team of people and to provide this integrated multidisciplinary care. Thank you. And I will just finish by wishing Alan Carson happy birthday. It's his birthday today. So.